Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for February is Child Health Research. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. And we also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this community, our province, and the country. We're delighted today to speak with Dr. Jessie Holst and Roseanne Nasser to bring you Advancing Pediatric Nutrition Care in Canadian Hospitals, an update on the nutrition pathway and malnutrition standard. Before we begin, we invite you to answer a few quick poll questions for us. Just note that you will have to answer all three questions to submit your response. And while Michelle is launching our poll, I'd like to take an opportunity to introduce our speakers today. Dr. Jessie Holtz is a staff gastroenterologist in the Division of Gastroenterology, Hepatology, and Nutrition at the Hospital for Sick Children in Toronto. And she's an associate professor in the Department of Pediatrics and Department of Nutritional Sciences at the University of Toronto. In 2009, she developed a simple nutritional risk screening tool called Strong Kids, which is used in multiple hospitals around the world. As the chair of the pediatric section of the Dutch Malnutrition Task Force, she was involved in the development and implementation of a nationwide pediatric malnutrition pathway and the development of mandatory national hospital quality indicators on pediatric nutrition. Jessie's also the current co-chair of the Pediatric Working Group of the Canadian Malnutrition Task Force and is working on the implementation of the pediatric malnutrition pathway in Canada. Roseanne Nasser is a research dietitian in the Saskatchewan Health Authority in Regina, Saskatchewan. As a co-chair of the Canadian Malnutrition Task Force, she has been instrumental in promoting nutrition care, knowledge, and optimal practice through research and education activities. Roseanne has participated in several research studies to prevent, detect, and treat malnutrition in hospitalized adults, and was awarded the Fellows of Dietitians of Canada for her professional contributions and leadership in dietetics. During the presentation, we welcome you to converse in the chat box and type your questions in the question and answer box, and I'll pose those questions to our speakers at the end of the session. It's now my pleasure to pass the mic to Jessie.
Hi, everyone. Thanks so much for the kind introduction and for the opportunity to present. It's our pleasure to give you an update on the nutrition pathway and malnutrition standards focused on children. These are our disclosures. So, and the learning objectives of today are outlined here. So by the end of the session, we hope that attendees will be able to become familiar with the prevalence of malnutrition in hospitalized children and its consequences, to understand the evidence-based practical strategies for multidisciplinary approach to manage malnutrition throughout the child's hospital stay and on discharge, and to describe select components of the evidence-based National Malnutrition Standard and what this will mean for clinician, patients, and their families. So this is an outline. I will cover the first part of the presentation, and Roseanne will do the second part. So we'll give some background about the Canadian Malnutrition Task Force, tell you more about pediatric malnutrition in Canadian hospitals, also a brief case study to highlight certain parts of the standard, and then discuss resources to prevent, detect, and treat malnutrition. So as a background, the Canadian Malnutrition Task Force is a group of clinicians, decision makers, and investigators forming a standing committee of the Canadian Nutrition Society. It consists of an advisory committee, which you can see here on the left, and then there's nowadays 4 working groups, of which Pediatrics is one, and I'm co-leading with Kim Brunette-Wood this group since 2019. So the Pediatric Working Group was launched in 2018 and currently has 15 members, with most provinces are represented. The CMTF has a great website, so you can see that here. And in the past few years, it has also now been populated with pediatric content, to which all of the members of the Pediatric Working Group have contributed. So when you go to Nutrition Care in Canada, you can find the pediatric content here under the Pediatrics button. And there you can find like the pathway that we will describe and all its components and background literature and practice tools which are available. So I welcome everyone to take a look. So just to start off with the first polling question, what do you think is the prevalence of malnutrition of hospitalized children when they enter the hospital, so upon admission in Canada? Is it 0 to 9%, 10 to 20%, 21 to 30%, or more than 30%? Please provide your answer. All right, I don't see any results yet. Maybe that's just me. Okay, well, I don't know if
I'm seeing that about 57% rated at C, 20 to 30%, 31% at B, 10 to 20%, and 13% at D, 31 to 40%.
Okay, all right, thank you. I don't know why I can see it, but that's helpful. And so we will come back to this question in the following slides. So why do we need to advance malnutrition in the malnutrition agenda in hospitals? So we know that children are at risk of developing malnutrition during hospitalization, and that evaluation of nutritional status and provision of adequate nutritional care are really crucial in the management of hospitalized children. But we also know that malnutrition is quite common. So depending on what criteria are used, it's 1 in every 3 to 5 children. So that would mean answer C was the most correct. It's also known that during hospital stay, attention is usually focused on medical problems, and little attention is given to nutrition or nutritional status. And malnutrition is the second disease that patient can acquire while they're in hospital. And of course, it is known that malnutrition is associated with adverse clinical outcomes, poor growth, increased length of stay, and increased resource utilization. I will address this a little bit more. So there are many factors that can contribute to malnutrition and malnutrition risk, of which some are relating to being a pediatric patient as opposed to children. Because children have higher energy needs per unit of body mass, they have increased calories needed for growth, especially at young age. There's a limited stores available usually in terms of fat and muscle, and they're also dependent on adults to feed them. That's another factor. And there can be like communication difficulties or separation or psychoaffective issues that play a role in obtaining food or expressing that they're hungry. And then, of course, there's the disease factor. Other factors are related more to healthcare providers. We know that nutrition training is fairly limited throughout the different curricula. And then again, the emphasis is on the medical care in the hospital and what brought the patient in, and not so, and that's the focus, like the diagnosis and the treatment of that particular disease. And there's less focus on nutritional status. And then there's also factors related more to like organization than hospitals, that a lot of times there's like inadequate measuring tools or technique. Weight may be unavailable, although in pediatrics we're pretty good at doing weights, not so much height or length, but weight is usually good. There's also that, you know, there's unclear responsibilities of the interprofessional team, lack of clear or systematic protocols, also unnecessary like MPO status for various tests. So all these factors can contribute to the child being at risk for deterioration of nutritional status. So just to go back to what are we talking about? So how do we define pediatric malnutrition? So a commonly used definition is from the Aspen Society, the American Society of Parental and Enteral Nutrition. And it states that pediatric malnutrition or undernutrition is defined as an imbalance between nutrient requirements and intake that result in cumulative deficits of energy, protein, and or micronutrients, which then may negatively affect outcomes such as growth and development. This is a great like overview that comes from the same paper that provides like key concepts about different mechanisms of pediatric malnutrition and also in relation to outcomes. And just to focus on the mechanisms. So in general, there's three main groups of causes for poor nutritional status, and they can all be present in one patient. That's also possible. So the first group is like decreased intake or starvation, which is then usually disease associated, but there could also be pre-existing problems with poor appetite, feeding problems. The second big group is about nutritional losses, for example, through malabsorption or through vomiting or through burns like wounds. And then the third major group is about increased nutritional needs because of the catabolic effects of disease or the need to have catch-up growth, or, for example, increased work of breathing that leads to like higher demands. And then there's also an important role of inflammation that's more and more recognized because it can alter the utilization of nutrients and also create, lead into the hypermetabolism part. So then just to outline the different types of malnutrition that can be present, I think most of you will know. So there can be acute, chronic, and a mixed type of malnutrition. So in the acute type, you see that the boy has a normal height compared to the healthy boy, but is very skinny, he lost weight. So this is also called wasting. The second type is chronic malnutrition, and when you wouldn't know the patient's age, you could see that, oh, maybe he looks pretty good, but as you could see compared to the normal child, he has lost like height, so he is stunted, and that can be a sign of chronic malnutrition. And then the mixed type of malnutrition is that it has both acute and chronic elements. So both height and weight for height are reduced. Just to keep in mind. So a little bit more about the prevalence of malnutrition, the polling questions. So how frequently is it seen in our hospitalized children? So this is just an overview of all the studies published in the last 15 years about the prevalence of malnutrition in a mixed population. And as you can see, various kind of criteria are used. So some use weight for age, some use BMI for age, others use height for age. And commonly it's mentioned like below -2 standard deviation as a cutoff to define malnutrition in these studies. And as you can see here, for acute malnutrition, it's between 2.5% and 22%. If you would look into more specific disease groups, such as congenital heart disease or cystic fibrosis or children with neurological impairment, these percentages will be higher. So just focusing on Canada, these are the studies that were done in pediatric hospitals in Canada. And the two most recent studies done in 2018 and 2019, the prevalence of malnutrition was about 19% when you base it on anthropometry, like the weight and height and BMI parameters, and higher if you would use a subjective global nutritional assessment. So that's taking into account more than just weight and height. When looking at the percentage of children with the deterioration of nutritional status during admission, there's fewer studies available. The studies that were published are depicted here, and that generally they used weight loss more than 2% or more than 5% as parameters. And the risk factors that were found for weight loss during hospitalization were a prolonged length of stay, having a pneumonia, a young age, and having a high risk score on the nutritional screening. So we will come back to that. Also, there was a recent collaborative multi-center Canadian study that was coordinated by the Canadian Nutrition Society that looked at nutritional deterioration during admission. So I will just give a little bit more detail about that study. So this was a multi-center study in 5 centers, and the goal was to assess the prevalence, the causes, and the consequences of malnutrition, to assess also the evolution of the patient's nutritional status during hospitalization. So patients between age 1 and 18 years with an expected stay of at least 48 hours were included. So in total, 37 patients were included with a median age of 5.3 years and a median length of stay in the hospital of 5 days. And just focused on the changes during the hospitalization, the results show that about 48% of the patient lost weight, of which 18% was over 5%. So that's considered like clinically relevant. And overall, there was a decrease in weight for age Z scores from -0.09 to -0.14, which was significant. And again, they looked at associated factors, and a lot were similar to the previous studies. But what was new was that also the patients who were not visited by a dietitian, of those who were, they had a worsening of their Z scores and focus on energy intake as well. So this figure shows the patients that had weight loss and a decrease in weight for age Z scores, and then classified as if they had an RD visit or not. So the black boxes is the patient that did not see a dietitian, and the gray ones they did see. And you can see that the percentage of weight loss and the percentage of changes in weight for age Z scores are lower in the group that saw a dietitian. Just to highlight the importance. All right, so moving on to the consequences of malnutrition. So in general, studies have shown that malnutrition is associated with increased morbidity, more difficult wound healing, increased risk of infections and other complications, and longer time to recovery, and also muscle wasting. So this all affects quality of life, but also can affect mortality risk, the need for other treatments, and increased length of stay in hospitals, which of course all would increase costs. Good studies, like specifically in children about long-term outcomes, are lacking, but there are some studies that have showed malnutrition and longer length of stay in the hospital and in the ICU, and also longer ventilator dependency and hospital-acquired infections. And we all know that in children specifically, there can be long-term impact on growth and brain development, and other lifelong implications such as decreased bone health. So in order to improve the recognition of malnutrition and malnutrition risk, and to improve the assessment and treatment of malnourished children, and thereby optimizing outcome, clinical pathways have been designed and put in place in some countries. And the various steps of such a pathway in general is about assessment of risk, assessment of status, then to come up with a plan, then to monitor what's happening during hospitalization, leading into a discharge plan and follow-up. So in Canada, there is a pathway that has been established in adult care. It's called INPAC, and that is used since about like 5-6 years. Maybe even longer, but in pediatrics, such a pathway did not exist. So as a goal of the pediatric working group of the Canadian Malnutrition Task Force, we wanted to go into developing a pediatric pathway. And as a first steps toward this, we did a survey among Canadian like children's hospitals to obtain information about the current practices of all the pillars of malnutrition care, such as screening, assessment, treatment, and monitoring and follow-up. So we did an electronic survey that was sent out to all the territory pediatric hospitals, which was disseminated to the various healthcare providers. And we did not include the ED and the critical care and NICU units. So the results showed that we had 120 responses, and that almost 90% of the hospitals that responded had no overarching nutrition protocol for managing malnutrition in the hospital. Also, the use of screening tools was very limited. There was like a protocol in place in about 42% of the hospitals about measurement techniques and equipment, and also the frequency to do measurements. But 48% had there was a lack of nutritional follow-up after admission for children who would be diagnosed with a poor nutritional status. That's good to keep in mind. So after the survey, the pediatric working group has developed the PINPAC pathway, so the pediatric integrated pathway for acute nutrition care. So that is kind of a similar name to the adult pathway. And we developed it through multiple Delphi rounds. So a first version was created in April 2020, and which was further modified to the version that I show here. So PINPAC is developed for hospitalized children aged 30 days to 18 years of age, and the NICU and critical care are excluded. And as you can see here, it's very busy, but it is very comprehensive and has different steps. So admission, day one, and after the rest of the stay during the hospital, in the hospital. But before I go into each of these steps, I want to make sure that everybody understands that there's differences between what we call screening and assessment. So nutritional screening is a quick and simple process aiming to identify individuals who are at risk of developing malnutrition. So validated pediatric nutritional screening tools are available for this. For example, Strong Kids and PNST, which have both been used in the Canadian setting. Nutritional assessment, on the other hand, is a more detailed process and where you quantify the nutritional status and also the degree of malnutrition of an individual. So you need more, it's more comprehensive. And to make a malnutrition diagnosis, SGNA, Subjective Global Nutritional Assessment, can be used, which is like an abbreviated type of nutritional assessment. So in order to explain the steps of PINPAC, I wanted to discuss a common case on the pediatric ward. So this is Bushra. She's an ex-preterm neonate. So she's now 5 months corrected, and she was born after 28 weeks with a birth weight of 800 grams. And now she's admitted with respiratory distress, fever, and need for oxygen because of an RSV bronchiolitis. She has difficulties drinking for 3 days. She's coughing and with vomiting, has reduced diuresis, and also parents think that she lost weight. When you look at the child without like further exam, you think that she looks skinny and there's not a lot of subcutaneous fat. So just to keep this in mind for the second polling question. So the first step, as mentioned, is nutritional screening. And so it's advised to use a validated screening tool. And based on that, you can categorize the patient as having no risk or at risk for malnutrition. Unlike in the adult pathway, where there's no like mandatory weight or height assessments, we felt very strongly that in pediatrics we do want to obtain all the measurements. So if the child is screened as no risk, still the measurements need to be taken. And if any of them are below -2 Z-score, this would also lead to further assessment by a dietitian in forms of SGNA. So this is, for example, the Strong Kids tool. So it's a four question related to like intake, losses, the underlying condition, and also how you judge when you just look at the patients, what is the patient in a poor nutrition status or not. This can be done by nurses or other trained healthcare professionals and takes less than 5 minutes to complete. So there's a list of underlying illnesses with risk for malnutrition. And as you can see, prematurity up to a corrected age is part of it. And then there's classification into various risk categories. So with this in mind, can you try to come up with what you think is the nutrition risk for Bushra, the patient I presented? Would she have a low, moderate, high a nutrition risk, or are you unsure? Okay, I hope results are coming in.
They are right now 73% say high, 27% say moderate.
Okay. Oh yeah, I see it now. Thank you. Yeah, I'll move on for the sake of time. So I think that we have a very good, knowledgeable attendees here, because I would also score this patient as high risk. And actually on the Strong Kids screening tool, all the questions would be answered yes. So it's 5 points, which would mean high risk. So because Bushra was classified as high risk, the next step should be the SGNA, as I explained. This is performed by a trained dietitian, and it's an abbreviated nutritional assessment tool. It was originally developed in 2008 by Secker and Gigi Boy, and we have developed like an updated version of SGNA very recently to take into account like the currently used anthropometric criteria. So we changed the centile cutoffs to Z-scores for height for age and weight for age. And also we changed the use of ideal body weight to BMI and then the Z-scores. So that was published last year. And we are in the midst of developing an educational video on how to perform SGNA. This would be a video that takes you through all the different steps and what to think of when assessing a child's nutritional status. The updated version of the SGNA can be found on the CMTF website. So this has all the different elements, the history and the physical exam parts of SGNA. So going back to our case and trying to come up with an SGNA SGNA like diagnosis, these are the growth charts of Bushra. So luckily we have more than one point available. So this is the weight for each Z-score, Z-score, the length for each Z-score. On the right hand, you have weight for height and head circumference. And as you can see, the weight for 8 Z-scores is deteriorating because the curve is pretty flat. So at the moment, the weight for 8 Z-scores is like below the 3rd percentile or below -2. Height or length for 8 is going pretty well. That's still on the 50th percentile or 0 standard deviation score. And then weight for length is deteriorating as well. So in terms of the other history items in SGNA, the adequacy of intake is moderately reduced in Bushra. Current intake is decreased compared to usual. There's a change in this, the duration of the change is less than 2 weeks. There are some GI symptoms because she was vomiting when she was coughing, not for a long time. There's a severe reduction in functional capacity. And on exam, you don't really see any like real wasting or subcutaneous fat loss and no edema. So overall, if you put all these items together, I would come to a moderate degree of malnutrition. And then based on the next step in the PINPAC pathway, you can see what that would mean. It would mean that there's a comprehensive nutritional assessment that needs to take place with adequate advice about how to treat. And then also the part of discharge is important because the duration of stay is not long, but children may not be back to their usual nutritional status or optimized nutritional status. So follow-up is important. This is just to highlight that about the nutritional care that is attached to the different categories. We have several like detailed advices. And so for Bushra, it will be both standard and advanced and the post-discharge nutrition care elements. That would mean that as you get further assessed and then the dietitian contemplates the use of a nasogastric tube, but she recovers well, is able to drink more and can be discharged after 4 days. Weight was done at discharge, but it was not yet up. So the follow-up is important. And next to the follow-up, it's also important to have a plan in place before discharge and write that in the summary letter, including like details also about the weight and discussion about the feeding plan with caregivers is also important. So just as for me, my part to finish up, we were very happy to have been able to develop a CPS e-module about malnutrition care. And this is on the website. You can find the link and it will also discuss cases and the various steps. So I would advise to take a look. And we are also working on finalizing a toolkit with instructions and support documents about assessment of food intake, discharge communication, and promote the quality meal times. And next to that, we are working on an implementation study for the first 2 parts of PINPAC, the screening and SGNA. And this is going to happen in 3 hospitals on 1 ward in each hospital. And we hope to start this spring very soon. And more details will follow about this study. So in conclusion, for my part, we have developed a lot of resources for wards and hospitals to use. So I will now turn over to Roseanne, how to best proceed on a hospital level with regards to adopting the malnutrition care pathway.
Thanks, Jessie. You're just going to see me on the screen for 5 seconds and then I'm going to turn the video off. It's just where I'm located in the hospital. We just want to save a bit of the energy for the presentation here. So we are on polling question number 3. Have you heard of the Health Standard Organization Malnutrition Prevention, Detection, and Treatment Standard, CAN HSO 5066-2021? I'm looking to see if we've got any results. Nice. Okay, excellent. Thanks. So 30% of participants have heard of it and 64% have not. Well, then you're in the right place this morning. All right, next slide, please. So we'd like to start by providing you with some background as to what led to the development of this malnutrition standard by the Health Standards Organization. And in 2010, 2009, the Canadian Malnutrition Task Force came together. And what they wanted to do is they wanted to look at what is the prevalence of malnutrition in hospitals in Canada. And they did that by looking at 18 hospitals across Canada. And at that time, the focus was on adults because we needed to start somewhere. So what they did is they conducted this study across Canada. And what they found was up to 1 in 2 adults admitted to hospital are malnourished on admission. And with information like that, you can't just not sit there and not do anything about it. So one of the team members asked another team member, what are we going to do about it? So what they did was the team of the Canadian Malnutrition Task Force, they developed this nutrition care in older adults integrated nutrition care pathway for acute care, also known as IMPACT. And they developed this pathway, and then they thought, well, we need to test it out. So what they ended up doing is they did a pilot in 5 hospitals across Canada, and that was called the More to Eat study, and that was the phase 1. So it was successful in those 5 hospitals for on medicine units. And then what they wanted to do was, they've tried it in those 5 hospitals, and can they expand it? So what they did, they expanded it in 10 other hospitals, and they asked hospitals, can you spread it not only to 1 unit, but to 4 units? And they were very successful, these 10 hospitals, in expanding to 4 units. So there is an appetite to have this integrated nutrition care pathway. And this pathway also led to the development of the Pediatric integrated nutrition care pathway for acute care. And then with the evidence that was obtained in Canada, but also evidence that is around the world in terms of hospital malnutrition, we were able to work with the Health Standards Organization to develop a malnutrition standard for hospitals. And I'll tell you a little bit more about that. Next slide, please. I also just wanted to say that malnutrition has existed for a long time in our communities and in hospital. And this is the first time that there is a standard like this in Canada to look at malnutrition in adults, but also in pediatrics. So the Health Standards Organization is a separate organization, a separate entity in Canada. And what they do is they develop standards for healthcare and social service standards globally. And they have national standards of council, of Standards of Canada that have been approved by the Standards Council of Canada. And some of those, you may be familiar with them in your work in pediatric hospitals, is the Antimicrobial Stewardship Program, the Medication Management, and then there's also medication management for community-based organizations, and then there's palliative care services, but now there's the Malnutrition Prevention, Detection, and Treatment Standard as well. So what does this malnutrition standard look like? Well, it's a resource that can be purchased through the Health Standards Organization, and they go through a very, very thorough process. And we were very fortunate as we had a Canadian Malnutrition Working Group help with that development. And it's a very thorough process, and it's the standard was developed. It was sent out to the public in August to October of 2020, so anybody could review it and comment on it and provide feedback to identify what's missing or what we could improve on. And then a lot of that information was brought back to the working group. That information was incorporated, and the standard is actually written for adults and pediatrics, and it's in English and in French, and it was finally published in September of 2021. So Canada has a malnutrition standard for adults and pediatrics, and the Health Standards Organization has allowed us to share with you a few items here today. So we're looking forward to sharing some of that information with you today. Next slide, please. So the standard itself is actually divided into 9 sections, and today we're just going to highlight a piece on nutrition risk screening, but also in terms of nutrition assessment, just really quickly. Next slide, please. And just so that we're all on the same page, so there's a definition for malnutrition for adults, but there's also a definition for pediatrics. But in essence, it's a deficiency or imbalance between nutrient requirements and intake, resulting in cumulative deficits of energy, protein, and micronutrients that may negatively affect growth, and that's in pediatrics or kids. And then for adults, it's again very similar, deficiency or imbalance between energy and protein and other nutrient requirements, and acute or subacute chronic states of malnutrition. So the standard itself has a definition for adults and pediatrics on what malnutrition is. Next slide, please. So we're going to quickly show you what a snippet looks like in the Health Standard Organization's malnutrition standard. And it's actually divided into a few parts. So if you look on the right up here, there's the clause, and that's an introductory statement following the criteria. And it's not a goal statement, but it's just an introductory statement. The topic area is section 3, which is nutrition risk screening. And then we've got the criteria, which is 3.11, and it's the organization has a protocol to conduct and document nutrition risk screening for all patients within 24 to 48 hours of hospital admission or transfer. And the criteria is just the requirement, and that's based on evidence, and it describes what needs to be done. Then you've got the guidelines just underneath here, and that's just additional information to help understand what the criterion is about. It does not contain any new information or required technical content. And in any standard that is developed by the Health Standards Organization, there's going to be a measure, and that there's going to be that measure to evaluate the criterion, or the which is 3.11 here. But it's really how to measure to help us improve, measures how we are doing things, how we're doing on a unit, because if you don't measure, you can't get better, and you can't get information about what's going on your particular unit. So this one is specific to nutrition risk screening, and Jesse had talked about in PINPAC the importance of screening, and that should be done on admission within 24 to 48 hours. So this is just re-emphasizing the importance of nutrition risk screening on admission, and then the next step after that is assessment. Okay, so next slide, please. I quickly wanted to give you an example of some of the work that we have done here at the Pascal Hospital on a medicine unit, and it's really to show malnutrition screening and quality improvement measures to assess the screening process. And we've been monitoring how nutrition risk, malnutrition screening, we use those two interchangeably, is going on the unit. This is from the fall of 2021, so late summer and fall of 2021. And what you'll notice is that over time, like where your x-axis is time and the y-axis is the percentage of completed screening tools, you'll notice that over time, what happens is, we're doing pretty good, and then for a while there, and then getting into late July, beginning of August, we just drop off in terms of malnutrition. screening, and that it could be a reflection of a number of things, like being short-staffed on the unit, just very busy in general on the unit, so the malnutrition screening drops off. And it's, you know, having a quality measure like this to show your team is an opportunity to say, hey, we know that this is happening in July and August. We know that it picks up once we show the results. And it's the nice thing about healthcare is it's always a continuous quality improvement. We're always doing that to improve the care for patients, whether they're adults or pediatrics. But this is just an example of what can be done to share results and measure malnutrition screening. Okay, next slide, please. I wanted to just show you this other item, and it's actually under nutrition risk, but it's actually pertaining to weight. So it's 3.1.2. And as Jessie had mentioned in PINPAC, the importance of having those measures of height and length and weight in order to be able to assess how a child is growing. And if possible, it's important to do it within 24 to 48 hours of admission, and then at regular intervals, at least weekly after admission. And what's nice is that's the criterion, and then underneath we've got the guidelines, and there, you'll notice that specifically underneath there's specifics for pediatric patients. So it talks about length or height at admission, weighted admission, and then for pediatric patients under 2 years of age, a weight a minimum of 3 times a week, and that's for follow-up, and length twice a month if the child is in there for a longer length of stay. So these are just examples that a health standard organization has allowed us to share with you today, that is available in the health standards standard on malnutrition. And that standard is really a really important resource for hospitals and adults and pediatrics to know, you know, just to help guide and think about what we can do to raise the bar to improve patient care. Okay, all right, so next slide, please. So what can pediatric hospitals do to adopt the standard? You know, I think the most important thing to think about with this standard is it's not to think about doing it all on all the units all at once. Hospitals should think about, you know, trialing it on a unit and then having like champions and having a multidisciplinary team, because malnutrition and nutrition care is not just about the dietitian or the diet technician. It's really about a team approach, and it's really about starting on one unit, but also having the support of senior leadership, that this is important, that we need to start doing something about recognizing malnutrition in children on admission, because it just, you know, if you don't have the support from your senior leadership, your middle management leadership and your managers, then it's very hard for frontline staff to make change, to improve practice, to improve patient care. So it's important to think about the standard and implementing it on one unit first, seeing what works on that unit, and then thinking about expanding it. It's important to have a protocol or a pathway like PINPAC, which Jessie had mentioned, and to test it and expand it and have those quality measures and see what is working. And it's also important to realize that you can't do everything all at once. So maybe the first step is, hey, let's work on doing our weights and our heights. Let's see if we can get that done. And then, you know, is there a way that we can integrate a malnutrition screening tool as part of the nursing admission database? Or can the diet technician that is working at your hospital, can they be involved in doing the malnutrition screening and providing that information to the dietitian? And is it about, it could also be about the dietitian at rounds, explaining to the team or sharing with the team, this child is considered to be malnourished right now because of all the muscle loss and the fat loss that they've lost. Or just in team conferences, so it's about starting somewhere, and a standard will help organizations take a first step at where can we go from here. And it's about recognizing that malnutrition does exist in our communities, but it's also happening in our hospitals too. And it's important to prevent, detect, and treat it. We have something really exciting to share with you. This information is not only shared by us, but it's also being shared by the Health Standards Organization and Accreditation Canada. The Accreditation Canada is going to be piloting a required organizational practice. And that required organizational practice is just, it's a measure for accreditation. But right now, this is just preliminary, and it's just going to be piloted in a variety of hospitals in Canada. And it's to ascertain whether it's usable and feasible. So that's pretty exciting. And it was something that we want to let you guys know about. And it's really to address malnutrition. The results of that pilot ROP will be used to inform whether it proceeds to a required organizational practice with the Cumentum Global Accreditation Program in the future. But at this point, the malnutrition standard is not part of the Cumentum program for Accreditation Canada. There is a pilot going on, and it's just to see if it's going to be usable and feasible. All right, so your take-home message today. Well, hospital malnutrition occurs in up to 1 in 2 adults, but also in kids, 1 in 3 kids. That's almost 30% of kids admitted to hospitals are malnourished on admission. There are 16 pediatric hospitals in Canada. There's a number of resources to help to prevent, detect, and treat malnutrition on admission to hospital. There's the Pediatric Integrated Nutrition Care Pathway for Acute Care, the CPSE module that Jessie has been involved with. There's the CMTF website that Jessie showed you guys as well. There's the Malnutrition Standard by the Health Standards Organization. And there's a development of the subjective global nutrition assessment video that's also being worked on. Jessie highlighted that they're working on implementing the pediatric or integrated nutrition care pathway. So they're piloting that implementation in 3 pediatric hospitals in Canada, which is very, very exciting. And then there's also this pilot by Accreditation Canada of a required organizational practice in a number of hospitals across Canada related to the malnutrition standard. But it's also important to make sure that it's a team sport and to create awareness about the prevention, detection, and treatment of malnutrition. All right, thank you so much. And we're happy to take any questions at this time.
Thank you, Jessie and Roseanne, for a great presentation. Our audience has a few positive comments and some questions. While I take a moment to get those sorted, we'll ask you to complete this next poll question and they'll help us improve our Spark program, and you'll have to select an answer to all 5 in order to submit your questions. So while you are doing that, I've got a few questions here for you. Aaron asks, can you speak to the HSO standard and its link to the accreditation Cumentum program?
Sure, that's a great question. So right now, the standard, the malnutrition standard, is not part of the Cumentum program at all. The standard, think of the standard as a resource. It's like a book that anybody, anywhere can purchase and use as a reference to start making some changes. We're piloting, and I say we, but it's actually Accreditation Canada and Health Standards Organization are getting ready to pilot a potential required organizational practice. And then from there, they'll decide whether it becomes part of the Cumentum accreditation program.
Great, thanks. Carol says, I'm just wondering why some kids do not have a visit from a dietitian, as this might help to improve their nutritional status and outcomes. Is it not typical? Is it something you're recommending as part of the process?
Well, that's a good question. I think, I think if, a child is found to be at risk or malnourished, then the advice of a dietitian is very welcome and needed. But I think there could be several reasons for not being able to see a dietitian is the maybe a lack of resources or availability of dietitians, and also the length of stay a lot of times is short. So as I said, then the focus is more on what brought the child in, for example, pneumonia or something or another diagnosis. And if the child is ready to go home, from that perspective, they go. So that may be reasons why. And I think that's why also after hopefully having implemented screening and assessment in the hospital, I think the focus also has to be on how do we send our kids home and what happens there and how can the follow-up be optimized.
Wonderful. I'm assuming that part of the process is around that continuity of care in the standard?
There are some general kind of advices in the standard also about follow-up. Yeah, and transition, but it hasn't been the focus of the pediatric group so far, because we first have a lot of work to do, I think, in the hospital, but maybe Roseanne can speak to it, but in the adult working groups, a lot of focus is now also on what happens in the community, and we're trying to learn from that and work together also to improve the situation for peds.
Wonderful. And do you have a sense of whether there is an adequacy of dietetic or dietitian or nutritional support services in the community?
Good question. I think there's like opportunity to optimize kind of especially knowledge, like specific knowledge about children. And from my personal perspective, when trying to refer to the community, there can be challenges in finding dietitians, but especially also for ongoing support in children who need it. That's challenged because of funding problems.
Of course. Not limited to dietitians, mind you.
No.
Allison asks, is the community malnutrition rate of children the same as that you're seeing in hospitalized children, or?
No, well, I would not expect that. It has not been like studied in detail, but of course, there's more and more children with a chronic disease where their nutritional status may be affected and who are managed mostly at home or at an outpatient base. But I would expect the prevalence to be lower. In a previous study back in the Netherlands, when I used to work there, we did do like a study in community hospitals, and there was still children where about 10 to 15% of children were found to be malnourished on admission. So it's a bit lower than in the specialized hospitals, but it's still there. And that may reflect also a little bit more about the prevalence in the community. But I expect it to be like lower than 10%.
Yeah. Krista asks, do you recommend the use of MUAC measurements in determining the risk of malnutrition?
Well, that's a very good question, and mid-upper arm circumference is a very good way to quickly assess kind of or get a sense of nutritional status, especially in children where like false weight could be an issue, or in cases of edema, or in cases of ascites or anything like that, or when a weight or scale is not available or children cannot stand on it. So, for example, the neurological impaired children. And we also know that mid-upper arm circumference in the developing world is very commonly used as kind of like a first like assessment tool too. So there's some studies looking into the additional value of mid-upper arm compared to, in addition to weight and height. And I don't know if it's well studied, but I think it did not really add in that sense. But I think it was not focused on the right group. So I think in those patients where weight and height are not available, it can be really helpful. Yeah.
Wonderful, thank you. A few people have asked for your slides. I understand you'll need to make some adaptations to them, and then we can share them via our website. So once we get them from you, they'll be up on the website. And the last question for today, babies that are admitted with gastro typically present with dehydration affecting anthropometric measurements. Should weight and length be assessed upon admission or once rehydration has taken place?
Yeah, that's a good question that comes back often. I think, it's good to do like in the terms of processes to do it like standardized as soon as possible after admission. But you're right, if the dehydration is more the cause of the low weight, for example, then it's good to do it again after rehydration. I think nowadays to be admitted with a gastro, you are usually quite sick. And so in most children who are admitted with a gastro, I think there would be some form of like weight loss, not only a low weight because of dehydration. So what I think it would be good to follow up weights throughout. Yeah. That's
wonderful. Thank you. That's the end of our time together today. Thank you, Jessie and Roseanne, for sharing your time and expertise with us. Thanks to our audience members for joining in. We know how busy you are, and we hope you take back some practical tips to bring back to your organization. And certainly you have the standard available to you. Coming up on Spark in February, still in Child Health Research Month, we have a Conversations podcast with Dr. Jason Berman of the CHIO Research Institute on child health research, thinking outside the typical healthcare system box. And in February, we have two more live webinars, one on February 15th, delivering high quality care through patient and family partnerships in pediatric research with our colleagues from PERN. And on February 23rd, in association with Kids and Vaccines Day, improving vaccine uptake, prioritizing pain and fear management during the immunization experience. So thank you so much for your time today. Thanks to Jessie and Roseanne for the presentation, and hopefully we'll see many of you back here next week. Bye, everyone.